All right, good morning, everybody. I got 9:01, so in the interest of all your time, we'll go and get started. I appreciate everybody being here this morning. So we're obviously going to start with our usual welcome. Got a couple kudos. I do have a pretty good call review for us today. We actually have a room for improvement, one I thought we could talk about a little bit. We'll go through our usual metrics and then chat it up at the end. So I just wanted to give a kudos to the St. Louis Congenital Heart Walk. They put on a great event every year. Certainly recommend if you guys got some free time, want to come out. I think that picture sums it up pretty well. Bunch of kids wearing awesome shirts. It's usually also always cold and rainy, and there are bubbles everywhere. So just an excellent summary of the event, but it's a good time. They put on a lot of good stuff for the kiddos, and it's fun to see the kids meet their heart teams and their docs that take care of them. So in a non-emergent setting, I'll point out. Also, shout out to Nixa Fire Department. They kind of encountered something a few of the districts up here in St. Louis have. They realized that they had a school in their area that was accepting countywide transfers for a lot of the high-risk medical kids who are school-bound, kind of recognized some deficits in their training and wanted to put together classes and coursework to take care of it. So obviously that's where a lot of our St. Louis-based agencies started too. So just kind of kudos to see the concept spreading across the state. Also, home of Jason Bourne, just in case you guys didn't know. All right, we're gonna do our call review. So this is a call that happened, you can see October 8th. We have a seizure call. This is for a kiddo, well known to the program, well known to his agency for status epilepticus events. And we can see we got an afternoon call this time as opposed to the middle of the night, which is always courteous of the kids. I appreciate that. History of the epilepsy, hydrocephalus of AP shunt, autism. We can see we have developmental delays, an active child with the developmental delays. Can see that we kind of have a description of some atypical seizures that he tends to have, but mom and dad are very good at picking up on them. Also included his medication list. You can see we got some of the extensive neuromeds. And I just wanted to include, from his seizure action plan, what is supposed to happen. And I'm going to point out this is, once again, every kid is unique unto themselves sometimes. This isn't even a typical seizure action plan, which is much more in line with our sees 5 minutes, give a dose, sees another 5 minutes, give another dose, then activate 911. Kind of to acknowledge that this kid is super status epilepticus prone. 911 is to be activated on the first dosing. And we're giving pretty substantial doses. There are 15 milligrams of diastep. So did want to bring up their primary assessment. I don't, of course, I don't get quite the pediatric assessment triangle from trip sheets, but we'll go for the next one down. Kind of notice snoring and possibly some airway obstruction from the tongue.
You muted yourself, Nick.
Oh, muted me. That's impressive. I didn't know that was possible in this world. All right. Kudos to you, whoever pulled that off. All right. So wherever I was, primary assessment. So partial obstruction of the tongue, cap refill. We can see probably intact circulation, tachypnic, and some abnormal motor there. They did apply their oxygen, so just like after every great primary assessment, we start implementing from our PAT and our primary. So went for oxygen, went for at the time the appropriate dosing of Versed frontline. They did note that the seizure stopped for 2 minutes after the Versed administration, but then the patient began to seize again. I will point out that was intranasal route. I know that's in some of your protocols. We do continue to advocate for intermuscular over intranasal. We think it's probably a bit more effective. Less is, I think I've taught most of you, but the fancy line from neurology is the bioefficacy of intranasal Versed is 42%, which is a fancy way of saying we're not sure how much drug is clinging to boogers or running down the back of the throat as opposed to being absorbed in the capillary beds. So that's why we kind of advocate for the intramuscular route. At least you know it's on board and being absorbed. So you can see first set of vital signs was actually kind of substantially later into the call. For some reasons you'll see shortly, treatment got pretty extensive here. But we do see, despite the kid having decent color and cap refill, pretty low O2 sats. And that's despite receiving the oxygen via or nasal cannula. And so very shortly in that time period, you see they're starting to pick up the BVM as well and bag the kiddo. Of course, primary impression being seizure. All right, so for treatments, they did pick up the BVM. Also in the intermittent time period, we had 4 missed IVs. Unfortunately, also a missed IO. We can see actually they placed the IO, but after administration of the bolus, it appeared that there was some swelling to the site. Also, father informed them that there had been abscess at the site. So I don't know how obvious it was or wasn't as far as when they did the initial placement, but they did DC the IO at that time, which seems appropriate. We did establish on the 5th IV attempt, they got an EJ with a 22 gauge on a kid, which that is not easy. So kudos to them for getting access. Also at this time, they're kind of acknowledging that they really thought that the airway was in some danger with lots of secretions. I don't know, potentially some challenges bagging the kiddo, and opted for a drug-assisted intubation. All right, so here's just the whole screen for the drug assisted. They did use, as far as the McGrath, so assume video laryngoscope, which I feel much more comfortable with as far as positive in placement. They did confirm with ETCO2. We did use ketamine as the induction agent and rocuronium as the paralyzing agent. They documented the depth and all that good stuff. Good post-intubation management documentation on this one, as far as and will carry in the documentation as far as OG2 placement, decompress the stomach from there, and then gave some pain management for post-sedation as well. All right, and then this is just hospital course after the kiddo got to us. Did, of course, go to the PICU while intubated, received a Versed and a drip as well as a phosphonatoin load. We did have to adjust the tube just a little bit, but that was only after chest x-ray for us as well. Upon PICU admission, feverish, kind of an abnormal spinal tap initially, but after cultures, nothing was positive, and then eventually the antibiotics were all DC'd, and he went home after getting his PO back up to PO intake back up to normal. So while this is definitely one of the more challenging calls for this kiddo, this is not entirely new to him. He has had a year. As you can see, this is just 2023, his 5th transport, and I believe he's been intubated on 2 of them. So this kind of brings up some of the significant challenges EMS faces, right? And some of the ones we've discussed in some prior meetings here, but what do you do once your benzos aren't working? That's a significant challenge for EMS. Most services don't carry that second line AED, whether that's Keppra or Dilantin. So should we be doing ketamine? Is there enough research to support that? If you can't stop it, should you stop at an outside hospital, or should you still transport directly to specialty care? And I don't know if there's a one size fits all answer, depending on where you work and resources and closeness to hospitals. I will say I know Children's has several more plans with these now, and as of this call and another kiddo who lives in this vicinity, we've also started to write in some plans where, at least for these kids who are super status prone, we're going to recommend trying ketamine as part of your next line after your benzos. So, this is one of those where there's some limited, support, and I'm sure the docs on the line can speak to that even better than I. And I know there are more studies in progress, but it was kind of recommended by neuro, and it feels like the right thing to do versus letting kids seize for 30 minutes while crews bring them all the way to a hospital. So I was going to give you an example. of this plan as we kind of try to refine how we're going to do this. And so, you know, kind of trying to tier out what's going to happen. Like, hopefully you fix it at just the normal stage of the seizure action plan, right? Give them their diastatin and it stops, or we give them their front line of the benzo and it stops. But then, you know, kind of looking at, okay, if that does not work, what next? And if that doesn't work, what next? You know, a classic EMS algorithm. And so this is just an example of what some of you might start to see in some of your plans. I have this in 2 plans now, kind of, they're both unique to the kids, but if not this, then this, if not this, then this. And so if you receive a plan, if you receive a notice that you have a new kid in your area and you see something like this and you don't feel comfortable, you think it's time for us to do some training in again, please let me know. I will try to let you know if I'm putting plans like this in your area as well, and we'll see if it's time to come out and do some seizure training, and then talk specifically about the ketamine component. So one other thing I just wanted to draw attention to, only because this has come up in the last month twice now. This was a pretty substantial change to this plan. So we completely pulled it back out of the system and had the docs reapprove it. And so the agency actually noticed in the intervening time period. But just know that that is a reason why you might lose a plan for a minute. It did take, you know, a day just to get it reapproved, particularly on another one that there were some questions on. But I've now had that happen twice. So feel free to reach out to me, but that might be the answer, that we pulled it back because we felt like we needed physician reapproval. We changed enough of the care plan that we needed some support for it. So any questions on this one?
Hey, Nick, I just want to make a comment real quick. You said a couple of things. First of all, I think this patient is absolutely 100% a great candidate for ketamine. This is right, you know, early on in the research into ketamine for refractory seizures. I think these complex kids are going to be the easy target because they don't have a lot of great options. You know, you mentioned that the research, I think the evidence that ketamine has anti-epileptic properties is pretty clear. It's kind of deciding where that medication fits into all the other anti-epileptic drugs. In the hospital, I think that's a little bit more of a question because there's so many more tools. In the pre-hospital setting, where everything is done primarily on expert opinion and not really a lot of good evidence to support many of the things we do, I think this is an opportunity to start using this medication more frequently. 5 IV attempts is just, like, to me, I don't know if Steve's on the line. I think that's just an unacceptable situation. That patient should have been at the hospital in the time it takes to attempt 5 different IVs. And I understand the airway concerns and things like that. And I wasn't on scene, so I don't want to Monday morning quarterback everything that happened. But I think if you're attempting an IV 5 times, maybe that patient isn't as unstable as you are thinking that they are, because you have time to do that many IV attempts. So this is where IM ketamine, intramuscular ketamine, is such a great option. And I think we're going to be seeing this in the next, couple of years as the literature becomes more robust, that this is going from a 3rd, 4th, 5th line option to being maybe a 2nd line option, or even sooner, especially in these kids who get so much benzos, because there are complications from that. I mean, we can talk about the airway complications for ketamine, but it's actually a really safe medication, all things considered. And it's a lot safer than multiple doses of benzos where that patient's going to lose an airway. And I wonder how much of this airway compromise was patient related or was provider related, in the sense that they get a ton of benzos and then there's questions about whether the airway is safe or not. And then these patients end up getting RSI, which has its own downstream complications. We know there's psychological effects, PTSD, things like that from getting intubated in the field. We know we're not good with sedation pre-hospital when it comes to intubation. So avoiding that in any situation is really, really important. I think we're cautious when we say ketamine for seizures because there's not a lot of evidence yet. But I would say, back to that, look at half the things we do pre-hospital and there's little to no evidence for them. Yet we do them all the time. So I don't know that this should be any different. It's a safe medication. It's effective. And a 30-minute seizure has known downsides for that patient, whereas much more significant than giving that patient a big dose of ketamine in the field. So I think this is a great case, and I'm really happy you guys changed that plan.
Thanks.
Can I-
Those are, sorry, lots
Can
of
I
good
add
talk.
something?
Yeah, please do, Miss Stephanie.
So we see this patient very often. We have intubated him 3 times this year. And it is, as Dr. Finney suggests, as a result of giving him massive doses of benzos. Our crews recognized pretty early once they started they asked for ketamine. The hospitals refuse it because you don't usually get an EMS physician answer the phone. We have asked for ketamine in the past in our seizure protocol, but like Dr. Finney said, there was not a ton of evidence and we could never get consensus through our physician advisory board for that. So once we noticed that this particular child responds to the ketamine, because he'd stop seizing in the middle of the RSI because the ketamine would kick in. So we asked them to add that. We had been corresponding on this particular patient several times because the hospitals had asked us, can we carry Depakote? Can we carry phosphenicoid? Can we carry Keppra? And the answer was always no or maybe. We could maybe carry Keppra. We couldn't carry phosphenicoid because it has to be refrigerated. And they didn't want to add it to any main seizure protocol. So then we couldn't get a standardized dosing. So that's why we asked for ketamine for him. Also for that IV reason, he's a very hard stick. And he has had abscesses from previous IOs that we've given him. And so the family is very hesitant to let us try an IO because they don't want us to give him another bone infection. So these are all sort of compounding issues over time. And we just want to try to find a solution to keep him from going to status because we want to get him to Glennon. We're half an hour from Glennon from his house. The other option is to stop at a not Glennon facility and get some kind of phosphenicoid on board and then get him shipped down there. We're trying to do the best thing for the patient. And that's why we went in that direction.
Stephanie, it hurts my heart to hear that somebody said no to ketamine for you guys when you wanted it in this patient. That I hear your frustration. In fact, I think without too much disclosure, I think that one of your crews actually called Children's at one point to give ketamine to another patient with refractory seizures, and one of my co-faculty said no, and I was just like, I couldn't believe it afterwards. We had like a 20-minute conversation of why they should have said yes, but that is really frustrating, and I'm sorry that happened. But it sounds like you guys are moving in the right direction, and I think as soon as that becomes more of an accepted practice, you guys having to deal with this kind of an encounter is going to become less and less frequent because you will have that successful abatement of the seizure earlier on.
Yeah, and I was going to say earlier, and just kudos to Stephanie. I mean, a lot of this was prompted by SCAD asking for it. I think we continue to have a platform to address those issues. Like I do wish, Children's hadn't denied ketamine, but I know my ED has denied ketamine as well. So, I mean, this is still the platform where we can include Dr. Finney and Dr. Laffey, who can pull the right levers and address those issues. So hopefully we'll continue to diminish that. And yeah, I as far as us, we kind of are gathering our own data here, but in a world, maybe we'll see a STAR seizure protocol in the future here where it is try benzo, ketamine IM, place an high-gel if you're worried about the airway. But we're at least progressing towards a plan as compared to the last 25 to 30 years of, I don't know, something's going to happen, take them somewhere. Sorry, you guys don't have the tools. So hopefully we can continue to make progress on all of it. Thank you both for many of your excellent points on this one. I wanted to talk about a room for improvement one here real quick. So this was a call from last month for a trach kiddo. You can see where I directly steal all my scenarios out of real life calls that happen. The classic where we've increased the oxygenation, mom's having to suction the secretions a whole lot more, and was ready to go to the ED. All of that is appropriate. I'm glad they went and picked them up and brought them to the ED. There were just a couple of things I thought could be improved in the documentation. I hope these things maybe happened more in real life than they were documented. But for a nearly 30-minute transport, there was not really anything about whether they thought they should continue suctioning when mom said she's doing tons of increased suctioning. And then they just documented, and maybe this is just a blind error in the documentation, but If you have a kid with a trach and you tell me you did not assess the chest, the lung sounds, the heart sounds, that feels like possibly some room for some improvement there. And there was no end tidal documented at all either. So we, of course, just recommend that gold standard for transporting a kid, at least doing a spot SETCO2 check. And for the most part, on most kids, you probably should just leave it on as continuous. Treat that trach tube just like it's an ET tube, and monitor it the whole way to the hospital. So I'm hoping that was just a blind click through the boxes there, but lung sounds on my trach patients, please.
Can I make a recommendation for systems, like all systems?
Just
To get one of the biggest reasons our crews don't put the end tidal CO2 on in the past is because they have to separate the vent from the tube and they're scared of dislodging it. And so we have this airway disconnect wedge. It's in all the trach kits that if they take the bag with them, but they're like $1 or $2 per airway disconnect wedge. And your agency could easily order a box of 10 or 50 and deploy them into your airway kits that will help separate those two pieces without dislodging the trach. And so that was one of the recommendations that came out of our last trach training, was to purchase, boxes of these airway disconnect wedge, because they're very inexpensive and they are very helpful in getting compliance with that end tidal CO2 on trach patients.
Awesome. So yeah, they're obviously good for trachs. They're not a bad tool to have around just for any, like if your BBM compartment, your ET tube compartment, they're useful for all kinds of things respiratory. So yeah, just even for my BLS services here, like it's a useful tool to have next to your BBMs as well. So you never know as far as having to break apart circuits and bag in a patient or anything like that. So that is an excellent point, Stephanie. Thank you. All right, so just to run through our year-to-date metrics. Courtesy of early November, which this slide includes part of, with pretty substantial increase in patients meeting to meeting here. So 53 plus. You can see as far as October itself, the change wasn't that substantial. That's going to be early November where you're really going to see those numbers pick up. Dispatches were up for October, and you can see we're on a pretty quick pace for November as well. Emergency activations, just that continue, just slight increase in trends. 911 transport calls, we had 35 for the month of October. And respiratory distress and seizures continue to dominate. I don't see that changing, maybe possibly in my lifetime for kid calls, but you never know, I might get surprised sometime. If I change the title on this left one, this should be direct to Children's Hospital, past closest hospital, including what data we have from our Golisano and Children's partners as well. This and then the Cardinal Glennon number specific, if you subtract those out, as far as EMS crews, 123 transports direct to tertiary, 223 for the system for the year. 198 admitted, 75 disposed from the ED, and we don't know on 25. We continue to track those outside hospital times whenever we know a patient stops at an outside facility prior to making it to specialty care. And you can see average for the year is 161 minutes, which kind of in line with trauma numbers, I assume. I don't know, Ms. Lori can correct me, but I think that's our numbers kind of waver about in that area as well. And then something new Morel has been doing for us as well is kind of looking at what happens when the kiddo stops at an outside hospital, because sometimes that's 100% appropriate, right? As we just discussed in status epilepticus events, depending on where they're happening, or services that are really far away from specialty care. So we were just kind of, curious, like, what's happening? Are they spending 161 minutes there and just receiving a bolus of fluids and a little bit of oxygen, or are they getting the care that we would be giving them as well? What's above and beyond what EMS would be giving. And so that's something we're going to kind of continue to track over time as we try to refine this right place in the first place, and when it's appropriate to do it, and when it might be right to stop. So some more to come on all that. No non-transports registered yet for November. For October, we had 8. Some of that I believe is somewhat written. My Golisano friends are on here a little bit. I believe they have a seizure prone kiddo who's kind of generating maybe about half of those as they're trying to refine his medications at home. Reasons for non-transport calls, continued seizures is the predominant one. And then continue to look at when STARS is referenced in the report or not. So I did go and include November just because of all those numbers you saw on the first slide, but we're looking at just over 3 days to approve the plans by the docs. And as you can see, just lots of new plans being put into the system. For my October attendance awards, so Central County, Collinsville, Dispatch. I see Jeffco Dispatch is on there as well, and Lee Control Dispatch. And then I also wanted to thank, I know Melissa Stites is on here from East Central for helping me with kid placement. We do try to do as best we can in our STARS offices of knowing where the kids are and who the right dispatch is for them and secondary fire sometimes, but we do get it wrong. So please just, if you ever see that on a plan that comes through, please just let us know and we'll get it fixed. Speaking of some dispatch changes, this came through with our updates this fall, but I just wanted to make sure everybody was aware of them. Because of the rules on the dispatching of the text plan, there was a little bit of latitude in it before that has been removed. It is now a complete 2-hour window. So if the plan gets sent to your crews by text message, from the moment that it is sent, it's available to 2 hours via that link. They can click it as many times as they want during that 2 hours. But at the end of that 2 hours, it is completely closed and not accessible. So the rules on all of that have been fixed up and now work appropriately as they're supposed to. The one new thing, and people had asked for this at least a couple years ago, but I thought it was worth the super users on here knowing, you can now forward that text link. It'll still register and we'll see that multiple people opened it underneath your phone number, but at least for my dispatchers and for some of my STARS admins at the district, if you have a crew going on a call and you realize, oh crud, the truck phone number changed, we didn't update it in the STAR system, or they don't have a truck phone, but they have a personal phone that they have access to on the call, you can forward your text link to them and they will be able to access the plan for the 2-hour window for the emergency. Just continuing to try and improve ways we can get information out there at the time of the emergency. So we're working on different ways to do that. So I hope that's helpful, and always please let me know feedback if it works, it doesn't work, if it's challenging. But we just want to find ways to have the people at 3 a.m. get what they need to help these kiddos out. So. All right, so that is everything I had pre-planned. You poor people, I actually took you to 9:30 today. That's not common for me. So I will gladly hang on. I'm glad to discuss anything open session. But for everybody else who's got to run to the next meeting or on to the next thing, thank you for being here today, and I hope you have a great day.
Thank you, you too.
Nick, do you happen to have a date for that room for improvement call?
I can, for sure. I'll stop recording this too.